Welcome to our free health education webinar, Your Health, Your Future, Understanding Colorectal Cancer Risk. I'm Dr. Sheena Jane, Medical Director for Radiation Oncology and also the Executive Director for Redeemer Health Cancer Center. We're happy that you joined the conversation. Over the next hour, we'll dive into the critical topics of colorectal cancer awareness and prevention. Together, we'll explore the rising rates of colorectal cancer in younger adults, key risk factors like family history and genetics, and the vital role of early detection. You'll also learn about genetic counseling, updated screening guidelines, and practical steps you can take, like diet and lifestyle changes, to reduce your risk. With insight from our expert panel, we trust this session will empower you with the knowledge to take control of your health. So let's get started. I will be your moderator for today's event. You can learn a little bit more about me on the slide that we're showing now. At this time, I'm pleased to introduce your presenters for today. Dr. Leigh Gerson is a colorectal surgeon with significant experience in minimally invasive and robotic-assisted surgery. She focuses on a range of colon and rectal problems from benign conditions such as hemorrhoids, incontinence, diverticulitis, to cancer. She also performs colonoscopies and other diagnostic procedures. Dr. Gerson treats the whole person, not just their disease, listening carefully to patients and celebrating successful outcomes, whether simple or life-changing. After studying biomedical engineering at Cornell, Dr. Gerson went on to earn her medical degree from Philadelphia College of Osteopathic Medicine. She has completed fellowships in colon and rectal surgery, minimally invasive surgery, and is board certified in general surgery and colorectal surgery. Our second presenter today is Carol Zuber-Pator. Carol is a licensed and board certified genetic counselor with over 40 years of experience in cancer genetics. She combines precise science and conversation with individuals to assess their risk for disease and educate them about disease, inheritance, prevention, and management. Carol looks at many possible pathways to cancer development and works within a multidisciplinary team to recommend the right tests for information and possible treatment decisions. She seeks to understand her clients' stories to help them make informed decisions and develop genetic family histories that will be helpful for their descendants. Carol earned her master's degree in genetic counseling from the University of Pittsburgh. With that, I'll turn it over to Dr. Gerson.
Hi, all. Thank you so much for taking the time. I do know it's a beautiful day out there, but this is a quick overview of colon cancer and what you guys can do to help decrease your risk and help get screened. So topics we'll cover today are just a basic understanding of colorectal cancer risks, especially in the setting of increasing rise in colon cancer among younger patients. Key risk factors, including family history and genetic predispositions. A brief overview from Carol on what is genetic counseling, the critical role of early detection and prevention, go over some of the screening guidelines and some proactive steps for reducing your personal risk, the importance of nutrition and lifestyle choices. So understanding colorectal cancer and its importance. So colorectal cancer remains the third most commonly diagnosed cancer in over 45, but yet it is the second most common cause of cancer deaths in patients. In 2026, it is estimated that there will be approximately 158,000 new cases of colorectal in the United States and over 55,000 deaths from the disease. As we'll go over in a little bit more detail, but almost all colon cancers arise from polyps, which makes regular screening exams super important because that's what we're looking for. So regular screening exams can find colon and rectal cancers at early stages. And we know, and I'll go into detail about why that's important and why treating it early, you have a greater success for increase outcomes. So knowing your personal risk factors, such as your family history, your genetics, your age, and lifestyle, can help you guide prevention and screening decisions for each individual patient. So how does colon cancer form? It starts as a polyp. So if you look here on the left, you get some proliferation of tissue. Excuse me. Go back. Hyperproliferation of tissue. You get an adenoma in the progression, which is a small increase of tissue. It becomes a large polyp. These are still benign, and then you can get more and more dysplasia. So changes in tissue that leads to precancerous changes as you move along. So the importance is polyps are the starting point of cancer. So if we can catch cancer, mainly during colonoscopy in this area towards the left in the benign region, we can completely prevent colon cancer. So one of the few screenings that actually can prevent cancer. So some important statistics. So if you look at this, a little bit of a busy slide, but if you look at the top here, the pie chart, you can see the different percentages. So 37% of patients are diagnosed with colon cancer in a localized setting. So that's when the cancer is contained to the colon. 36 is when it's already spread to some lymph nodes, a little bit more advanced. 22% of patients already have distant metastasis. And the reason of that significance and why that's important is if you look below the 5-year survival, patients who are diagnosed with local disease, so a kind of a polyp that has some cancer in it or an actual colon cancer that's just contained to the colon, the 5-year survival is upwards of 90%. And you can see it decreasing significantly from down to 72% and then down to 14% if it's metastasized. So the importance of screening, especially with colonoscopy, is to find these cancers in the early settings. It really increases your risk of overall survival. And in general, 5-year overall survival for all comers is 64%. So the how you do with disease is really based on what point you're diagnosed. So what are your risks for colon cancer? We do know, like a lot of cancers, just as we age, unfortunately, our bodies have more years of turning over tissue and tissue. So just being older increases your risk. At the same time, we do know that the onset of early colorectal cancer has changed over the years. We know that things that we can control, though, like low fiber diets, but diets that are low in fruits and vegetables or high in red and processed meats, that those people tend to have higher incidence of colon cancer as well. We know that leading a sedentary lifestyle contributes to colon cancer. And then, like lots of other cancers, smoking or tobacco usage will also increase your risk. Being overweight or obese. And then some things we can't control, like autoimmune diseases or inflammatory bowel diseases such as Crohn's or ulcerative colitis, does increase your risk over the long term. In heavy alcohol use, and then things that we have a little less control over as well. So family history. So whether you have a family history of colon polyps or a family history of colon cancer in multiple relatives or first degree relatives puts you at increased risk. Being of the African American race or any other inherited risks, such as other genetic diseases, which Carol will touch on a little bit.
So, as a genetic counselor, I'm often asked, what is genetic counseling? And what is a genetic counselor? So I have a master's degree in genetics for genetic counseling. I'm board certified and licensed. And we named the field genetic counseling many, many years ago. It really is an education process rather than counseling. So a genetic counselor provides education, talks about genetics, assesses risk by analysis of pedigree, and then we help patients through the process of deciding whether pursuing a blood draw or saliva or genetic testing is appropriate for them. So, as a genetic counselor, I can't help but not talk a little bit about genetics. So, in the cells in our body that we analyze when we do a blood sample. And it's not the red blood cells, it's the white blood cells that we look at the DNA within them. And in the center of the nucleus of a white blood cell are our chromosomes. And our chromosomes, we have 46 of them, or 23 pairs. And our chromosomes are important to us because they carry our genes. A gene is a code or recipe that our body uses to make proteins. And ultimately, it's all about the protein. Because the proteins, for instance, that cancer gene, predisposition genes make are proteins that fix mistakes that happen during normal cell division within our body. And if those proteins aren't working correctly, then mistakes may build up and perhaps a tumor or cancer could develop. So when we talk about genetics in regard to cancer genetics, most of the genes are inherited in what we call an autosomal dominant way. And that means that we have 2 copies of the genes, and you only need 1 copy of a changed gene to be at risk for developing a cancer. So many times I hear patients and other people say, oh, I've got the BRCA gene, or I've got the BRCA1 gene, or BRCA2 gene. I use those as examples because they're more commonly known. I say, oh, that's great, because we're all supposed to have 2 copies of the BRCA1, and we're all supposed to have 2 copies of the BRCA2. So what we're doing when we do genetic testing is we're actually looking at the code or recipe of that gene to make sure the gene is intact and making the proper protein. As you can see on this next slide, the crux of genetic counseling surrounds this. This is our family tree or pedigree. We take it a little bit differently than maybe other disciplines do. It's actually a drawn out picture on one piece of paper, and circles are women and squares are men. And I try to go out 3 generations, and we fill in the circle or square according to what kind of cancer they might have had, when it was diagnosed, and then from there we try to go up and sidewards and fill out the family tree. What I look for in a pedigree that would make me concerned about the possibility of a germline or genetic change would be multi-generational cancers, and that goes back to that dominant mode of inheritance. For instance, if I carried a BRCA1 or BRCA2 gene or a cancer predisposition gene, I'd have half a chance of giving it and half a chance of not giving it every time I go to have a baby. So you tend to see within families where we're concerned about the presence of a germline mutation, we tend to see multi-generational cancer. And what germline means is that's the genetics that we received when the egg and sperm come together, and those are the genetics that we would find in the cells in our body that have a cell center and carry the chromosomes. So, what sorts of patients should be referred to genetics? Well, I have a pretty liberal or a stance to that. I think that many times until a pedigree is fully constructed, that one might not know their risks. So, but in general, we'd say obviously anybody who has colorectal cancer, age 50 and below, would be somebody that we would want to see. We'd want to see anybody who has a family history of precancerous or adenomatous polyps in themselves or a close family member. We'd like to see anybody who tells me that Uncle Joe has a mutation, PMS2 mutation for Lynch syndrome. Yes, that person should be referred to us for genetic counseling. Also, we tend to look for other cancers that can sometimes cluster with genes that can cause colorectal cancer. And there's a lot of those: colorectal cancer, endometrial cancer, ovarian cancer, bladder cancer, kidney cancer. The list goes on. Those are all part of the genes involved with Lynch syndrome. And as you can see in the next slide, there's a number of genes with Lynch syndrome. And Lynch syndrome is the largest subset of genetically inherited reasons for colorectal cancer and the other cancers listed here. It's named after Dr. Lynch, and so there's a number of different genes involved with Lynch syndrome, as you can see here. And in general, the MLH1, MSH2, MSH6, PMS2, these are genes that we all call as a group mismatch repair genes, which kind of tells you what they do. They fix mismatches that happen during cell division, during normal cell division. Since we're focusing on early cancer, in this next slide, you can see that about 1 in 4 to 1 in 5 individuals under the age of 50 may carry a pathogenic or likely pathogenic mutation. Now, what does that mean? Pathogenic means there's a change in the code of the gene and it's hurting the protein. Likely pathogenic means there's a change in the code of the gene, and we don't know for sure if it's hurting the protein, but we think it might be. Those are actionable test results. So if we looked at individuals 35 and younger, the chance for a germline pathogenic or likely pathogenic mutation may be even higher than this 20% cited here. And you can also see from this pie graph that we talk about Lynch syndrome, FAP, MAP, and other mutations that contribute towards colorectal cancer. Don't want to get into the itty bitty about it, but Lynch syndrome is the main one that we talk about. So in the next slide, you can see that no family is clean. No family history, just has colorectal cancer. There's usually, if you take a good enough pedigree, you can usually find other family members who might have breast or ovarian or pancreatic. And by the way, ovarian and pancreatic can cluster with the Lynch syndrome genes. So there is crossover between these types of syndromes and types of genes with cancer development. So enough of genetics, and how do you get to see a genetic counselor? For many people, as you can see, that's a mystery. No mystery involved. We have a society called National Society of Genetic Counselors. And if you Google that and toggle on the very first page, there's a button you can press that says find a genetic counselor, and that'll walk you through finding a genetic counselor across the country and even beyond. And it also asks you what kind of specialty you want. So if you're looking for a genetic counselor about neurology conditions, about prenatal conditions, pediatric conditions, those specialties will crop up too. How do you prepare for a genetic counseling appointment? Well, beware, I'm going to take a 3-generation pedigree. So finding out about first cousins, aunts and uncles, grandparents, maybe even grandparents, siblings, if possible, if the family is young enough and has that knowledge. So we want to know what type of cancer, what age of the cancer, whether they passed away from the cancer, and really, did anybody have genetic testing? And what was the result of that genetic testing? More and more families, if they're large enough, I find somebody who's been tested. And when you've been tested, I ask for the first page of that test result. That's all I need is the first page of the test result. What is the cost of genetic counseling? Well, Redeemer Health is ahead of the ball on this. We provide no-cost genetic counseling. So the chance to talk with me either by phone or in person is at no charge to the patient. Typically for the genetic testing itself, most of my patients are paying probably $0 to $100 out of pocket. And at most, there's a self-pay price of $250 or $249. Times have changed. You hear many stories about people who wanted to have genetic testing, but they were declined by their insurance, or it was going to cost thousands of dollars. That's all gone by the wayside. Testing has become very accessible and affordable. So after we have results, and results usually take about 2 weeks from a blood sample or a saliva sample, that's usually taken at our office, comprehensive breast care surgeons. With that result in hand, I call the patient or individual and inform them of their test result. If there's a pathogenic or likely pathogenic mutation, we talk about that in detail, and I'd make the appropriate referrals to a specialist as needed. If there's no mutation, I really emphasize to people that we didn't look at all 20,000 of your genes and you still have a family history of cancer. And then the third answer that we can get is, as I mentioned previously, it's called a variation of uncertain significance. And that means there's a change in the code of the gene. We don't act on it. And usually those get reclassified over the course of time to likely benign or benign. So it sounds ultra complicated, but it's really not. And I'm here and available for questions. So look forward to hearing from some of you. Thank you.
Thanks, Carol. So why is this important? Why do we need to worry about colon cancer? I'm sure lots of you guys have seen in the news, colon cancer is still a growing concern. So colorectal cancer is the #1 cause of cancer deaths in men under 50, and second, just to breast cancer in women under 50. So the rates of colon cancer continue to rise in the under 50 population. Younger patients often are have a later stage at onset due to kind of ignoring some rectal bleeding or chalking it up to other things because, colon cancer isn't really on their minds. So this is why this is important. I appreciate everybody being here today. This is why screening is so important. So again, the incidence in rising in the younger population, you can see on this map indication here. So what's good about screening is we have decreased the screening age from 50 to 45. So everyone over the age of 45 should be getting screened. We can see that these efforts have really worked. So the incidence of colon cancer has decreased by 32% in just 13 years in individuals over the age of 50. As likewise, mirroring that, the decrease in cancer deaths have decreased by 34% as well. But on the flip side, the incidence of cancer continues to rise in the under 50 population. So this is why it has led to some of the changes in the screening guidelines down to 45. So what are some of the signs and symptoms of colon cancer? What things should we be looking for? So some are pretty general, feeling tired, fatigued, noticing changes in your weight, some generic things. So bloating or gas, I usually say to my patients, changes in your bowel movements. So did you used to have big stools and now they're thinner? Have you had more diarrhea recently? Things like that are kind of prolonged, so more than 4 weeks. Abdominal pain, most importantly, blood in your stool. So whether that's a dark tarry blood, more of a blood in your stool, or bright red blood per rectum. A lot of times it can be other things, but it's important to get them checked out to make sure it's not something more significant. So different patients have different level of risk. Some of that is what Carol talked about, including family history. So an average risk patient, and why this is important, we'll get into it because it does affect what type of screening you are eligible for. So if you're an average risk patient, so that's patients 45 to 75 years of age, you have no personal history of cancer, polyps, or inflammatory bowel disease, and no family history. So no one in your family's had colon or rectal cancer, has large advanced polyps, and no inflammatory bowel disease. You need to be asymptomatic, so no rectal bleeding, no belly pain, no weight loss, and then no history of a childhood cancer or a cystic fibrosis. Anybody who doesn't fall into that category is inevitably going to be high risk. So patients who themselves have had cancer, colon cancer, or polyps, and anyone, any first degree relative, of colon cancer or colon polyp. So a parent, a sibling, or a child. If you have any genetic predisposition to cancer, specifically colon cancer, if you have a history of inflammatory bowel disease, or if you've had any abdominal cancer that has required radiation treatment. So this becomes important in terms of what screenings you should follow and what tests are available. So for an average risk patient, there's lots of different societies that give guidelines, but most of them are the same. So we recommend that all average risk patients, so no family history, no personal history of colon cancer, start getting screened at age 45. And we continue that at least until 75. Or if your life expectancy is 10 years. And we say 10 years for a lot of these screening guidelines, and that's because we think that's how long it takes from a polyp to turn to cancer. So that's where that 10 years comes into play. So the screening guidelines suggest that after the age of 75 and between 75 and 85, it's really a patient and physician discussion. So it's really based on your life expectancy, how you're doing, all your other medical comorbidities and things like that. And then after the age of 85, we no longer recommend screening. And what are these tests that are available? We recommend you can do colonoscopy, virtual colonoscopy, stool-based tests, so stool DNA tests, FIT tests, and now there are some discussion of blood tests as well. So who gets screened and when? If you have a family history of colon cancer, you should get screened 10 years younger than when your youngest family member was diagnosed, or at latest age 40. After that, you follow screening guidelines based on what your colonoscopy finds. So what are things we can do to help decrease our risk of colon cancer? Again, a lot of it is genetics and we have no control over it. But just as Carol was saying, just knowing your family history is important. So knowing that if you have a family history, you need to start getting screened earlier. Latest would be age 40 or 10 years younger than when your family member was diagnosed. And stay up to date with your screening. That really, as we know, God forbid you did find a cancer while you're on routine screening, the earlier you find it, the better you will do even with that cancer. And then pay attention to how you're doing, how your body's feeling, any significant changes in your bowel habits, any blood in your stool, or any unexplained weight loss. And then you'll see a lot of overlap with just kind of a healthy lifestyle in general for colon cancer, which is nice, but really high fiber foods, nuts, fruits, vegetables, all decrease your risk of colon cancer. I really try, and I'm paying more attention recently to limit any red or processed meats, anything like lunch meat, anything that's uber processed has really part of why we think there's an early onset of colon cancer. Activities. So aim to stay active. Just 150 minutes a week can really decrease your risks. And then things that we already know aren't good for us, especially these days, a lot about alcohol being bad for our health, smoking, and then just trying to maintain a healthy weight really does go a long way in decreasing your risk of colon cancer. So what can we take away from today's webinar? Colorectal cancer is preventable and treatable when it's detected early. So everybody should know their risk and know to get screened at the appropriate time. We know that younger adults are increasingly affected. So kind of getting the word out and talking to your loved ones and children and cousins. If they're talking about rectal bleeding or belly pain, don't just let them chalk it up to hemorrhoids. And that's kind of the most common presenting symptom I see in the office is bleeding. And then family history and genetics matter. So know your personal risk, talk about it with your doctor. If you're interested or eligible, go ahead and get genetic testing. The more information we have, the more ability we have to kind of control what we can control. And really the takeaway from this this presentation to be get your screening. So I'm sure there'll be some questions on, screening and what I recommend. And any screening is better than none. Obviously, colonoscopy is the gold standard, and it is both what I call it diagnostic and therapeutic. So it will say, do you have polyps? Do you have cancer? And also, if you do have polyps, you can remove those, which is how we go ahead and prevent cancer. There's lots of reasons why people don't get colonoscopy. So any other screening tools are good, but colonoscopy is still the gold standard. And then we do have some control. So maintaining a healthy diet, staying active, avoiding smoking, red meat, excessive alcohol, all decrease your risk of colon cancer. And just taking these small proactive steps can really help reduce your risk of colon cancer going forward.
Thank you, Dr. Gerson and Carol. That was extremely informative. At this time, we will begin the Q&A portion of today's program. You can still submit questions via the Q&A icon on your Zoom menu at the bottom of the screen. We'll do our best to answer as many questions as possible before the end of the webinar. Leigh and Carol, the first question that we got is, what advice would you give to someone who is hesitant to get screened for colorectal cancer?
So I talk to patients a lot in the office. I think just the uncertainty of not knowing and the anxiety of not knowing prevents a lot of people from taking that next step. So I find that, having someone support you through it, and then once you know, and there's treatment. Colon and rectal cancer is a very treatable cancer, as you saw in the first slides. If you're found with an early cancer, you have a 90.6% chance of 5-year survival. That's an excellent prognosis for cancer. So don't be scared. Just kind of rip your Band-Aid off and do it. You'll be much happier knowing than kind of getting diagnosed with the same problem much later down with less treatment options.
Thank you, Dr. Gerson. That actually leads us to our next question, Dr. Gerson, which might be a good one for you. Why do we quote 5-year survival, and especially when you can remove it before metastasis? Can you elaborate on that a little bit?
So we talk about 5-year survival just as a barometer of how we kind of guide treatment for cancers and kind of a way to standardize discussing treatment for colon or for every cancer. But so when you're saying for like metastatic cancer, a lot of time people don't have 5 years. So I see what you're saying, but it is just kind of one of the standard ways we talk about survival for cancers. Did I answer that question?
Yeah, I mean, and I agree with you. I think in our world of research for cancer, there has to be some standard that we use to compare research studies to. And so the nomenclature that we use, in our world as cancer doctors is what is the 5-year overall survival? Remember, not everyone who's not meeting those numbers, that doesn't mean they're dying of their cancer. Something else can happen in those 5 years. But it's just a way for doctors to communicate with each other and compare and contrast different treatment methods. So we're all speaking the same language. Carol, the next question I had was for you. How do you approach conversations with patients who are nervous about getting genetic testing?
That knowledge is power, same thing. If you know you have a germline mutation, be it pathogenic, likely pathogenic, we can refer you to a specialist. We can get your insurance to pay for enhanced screening in many circumstances. And so knowledge can be power, and early detection with colorectal cancer is the key.
Thank you, Carol. Next question is for you, Dr. Gerson. Hi, Dr. Gerson. I'm a 60-year-old female and get regular screenings with only a couple of polyps in the past 5 years. No family history of colon cancer. However, I have a tortuous colon. I've been told that my colonoscopies are challenging by doctors because of this. Does a tortuous colon put me at a higher risk for colon cancer? I don't have any symptoms, normal BMI, and I'm active and in good health, but I would like to know if I'm a higher risk. Thank you.
Yeah, absolutely not. So the only downside is for your colonoscopist. It makes no difference to you. It is harder for us, but for you, it makes no difference. Sometimes I have noticed that, especially in women who do tend to have these more tortuous colons, sometimes it's associated with increased constipation, but certainly no predisposition to cancer.
Wonderful. Thank you, Dr. Gerson. The next question we have is, there is multi-cancer blood testing available now. Which is better predictor for for testing? Is it genetic counseling or the blood test?
Hmm. Well, I think there's apples and oranges here. Genetic counseling allows you to take an assessment of your whole family to see what sorts of cancers there are and whether they follow a pattern that would make us concerned about the presence of a germline mutation. Once you have a germline mutation, that increases your risk for developing cancer. It doesn't say that you will have cancer. The panel testing that's coming about and highly advertised that looks at circulating tumor DNA is a different way of approaching. It's saying, do we have evidence from the circulating tumor DNA that there is tumor from or DNA from a tumor that's being shed, be it various tumors are involved in the tests. So it's telling you, hey, maybe we need to do further imaging or testing to see if indeed there is a cancer present.
Thank you, Carol. Dr. Gerson, the next question is for you. What is a virtual colonoscopy?
So a virtual colonoscopy is actually a CT scan. So it's like a CT colonography. So it is good for patients who it's kind of a very small subset of patients. So someone who might have had a very tortuous colon, like one of our questions, and they could not have a complete colonoscopy because it was too difficult to get through anatomically. Or maybe in a setting of a patient who is really high risk to undergo sedation or anesthesia. But what it is you still need to do a bowel prep, which is a common kind of misconception from patients. You do a bowel prep and then you do a special contrast, then a CAT scan. So it is pretty good for finding cancers, not as good, obviously, for finding small polyps because it's just the sensitivity. But the problem is, again, for most of these screening tests, if you have a positive CT colonography or virtual colonoscopy, you still then need a colonoscopy because that's how you actually diagnose the cancer or whatever you would see on one of these tests.
Thank you, Dr. Gerson. Carol, next question for you. How do you help patients navigate the emotional impact of learning they have a genetic predisposition to cancer?
Well, again, knowledge is power. Saying, actually, people sort of tend to react to my saying, hey, look, you've had this mutation your whole life since you were conceived. And when they hear that, they sort of de-escalate a little bit. So that's something that I've seen help people. It's not as though you have cancer. You have this germline mutation you've had since you were conceived. So, and now that we know you've got it, we can alert other family members about it, and we can provide you with better surveillance or management.
Thank you, Carol. Dr. Gerson, how do symptoms of colorectal cancer differ for younger patients, if at all?
Yeah, good question. So actually, they don't really differ. I think it's just kind of what we touched on. It's what patients are expecting. So I think younger patients, it's a busy time of our lives, whether you have, you're in school or have children, you're kind of not always focusing on yourself. So these little things that probably have been happening intermittently kind of creep up on you and you're not paying much attention. But it's still this kind of red flags. Unexplained weight loss, night sweats, rectal bleeding, belly pain, and changes in your bowel movements. I don't mean a fluctuation. I don't mean like sometimes I have diarrhea and sometimes I have constipation. It's more of like I used to have go to the bathroom every day and now I'm constipated and I'm not going as much, or my bowel movements look a little smaller, or I'm having chronic diarrhea. It's those things that aren't going back and forth. It's kind of sticking. So just the kind of take home is take care of yourself. There's no silly reason to go see a doctor, especially me. Good news is rectal bleeding still is often hemorrhoids, but it would just be such a shame to miss something early when it is so treatable.
Thank you, Dr. Gerson. Carol, this next question's for you. Since family history plays a role in colorectal cancer, does having a family history of pancreatic cancer also increase my risk for having colorectal cancer?
Well, certainly any case of pancreatic cancer within a family tree is something to pay good attention to. They think that about 10% of pancreatic cancer cases may be due to a germline mutation. That number might be to 7 to 10%, but it's around there. So one of the most common ones, surprisingly or not surprisingly, is the BRCA2 mutation, but there's a number of other mutations, including some of the Lynch syndrome genes and other other mutations for breast cancer like ATM that can also contribute towards pancreatic cancer. So any history of pancreatic cancer within the family is something to pay attention to. And unfortunately, I actually just heard a patient tell me today that her mother has 4 first-degree relatives with pancreatic cancer, and 2 of them were recently diagnosed and died within a month of their diagnosis. So we don't get to those individuals in a timely enough manner to provide them with genetic test results for the other family members.
Thank you, Carol. Next question. I thought colon cancer screening was either a stool sample or a colonoscopy, not genetic testing. Do you only get genetic testing once you've been diagnosed?
Sorry, what was it again?
The question was, I'm going to have to go back to this, sorry. I thought colon cancer screening was either a stool sample or colonoscopy, not genetic testing. Do you only get genetic counseling if you already have colon cancer?
No, that's not true at all. If you have a history of having precancerous polyps, that would be a reason to talk to a genetic counselor, or a family history of a first degree, second degree, and even a third degree relative who has colorectal cancer at an early age, or look for that pattern within the family of multi-generational cancers, early onset cancer. No, genetic counseling is just the talking part of things.
Thank you, Carol. Dr. Gerson, what's one innovation in colorectal cancer that you're most excited about right now?
So, this is more for rectal cancer. The idea of total neoadjuvant treatment. So, a rectal cancer based on its anatomic location, so kind of being out of the abdomen, lower in the pelvis, makes it a really good area to be targeted for radiation therapy. So Dr. Jane and I kind of work in conjunction with each other, that a lot of patients with rectal cancer get chemotherapy and then chemoradiation therapy, and often have a really good response, and sometimes don't even need surgery. So I think the treatment of rectal cancer has really come a long way, and that's something that will hopefully continue to change and continue to grow.
So
I
I'm sorry. So also with colorectal cancer, it's kind of going deep into genetics, but sometimes the pathology of the tumor or a large polyp may lead us in the direction of thinking that certain types of therapy or treatment may be more advantageous. So that's happening out there. And the other thing that I see happening in colorectal cancer treatment is the use of circulating tumor DNA to monitor recurrence for patients. And that's being used quite commonly with colorectal cancer patients who are surviving.
Absolutely. I agree, Leigh and Carol, with both of your answers. I think, Leigh, for rectal cancer, I think it's very exciting when we can try to de-escalate our therapies. Our patients go through so much, as you mentioned, for rectal cancer. Sometimes it's radiation and chemotherapy and surgery. If we can de-escalate therapy and try to remove some of those components, it means, less that our patients have to go through, less side effects, better quality of life. And at the certainly not at the cost of decreasing our survival and our cure rates. And so in these studies, we're seeing equivalent outcomes, even while we're de-escalating therapy. And I think that's something that's extremely exciting in the field. And Carol, I agree with you. I think the ability to use circulating tumor cells. So this is typically a blood test that's done, that can help monitor for recurrence. And sometimes we can catch recurrences much sooner than we used to, as physicians, because a lot of times we were reliant on the colonoscopies, we were reliant on the imaging. And so the field continues to advance. And I think that's an important message for the community members that joined us today, is that there's a lot of exciting things on the horizon. I'm going to switch to the next question. So I'm going to maybe send to Dr. Gerson. So because my father and grandmother and several great aunts and uncles on my mother's side have colon cancer, I've been getting colonoscopies every 6 years since I was 40. I'm now 74. Never once have they found a polyp for me. Does this mean I might have missed a gene for this, or could I use home tests instead?
So that's a great question. It kind of touches on a few things. So it does kind of highlight the importance of genetics. So you probably are not you should continue to get your screenings. Don't get me wrong. But I do find that if a patient doesn't make polyps, the chances of them having colon cancer is low, because we did look from the beginning that colon cancer starts as a polyp and then turns into cancer. If you've never had a polyp, then the chances of you having cancer are probably not at an elevated risk. That being said, the important thing to know is that with being a high-risk patient, meaning you do meet the criteria because you have family members with first-degree relatives with colon cancer, you actually are not eligible for any of those additional tests. So you cannot get CT colonography. You cannot do the Cologuard, which is a stool DNA test. You cannot do a FIT test. And you cannot do even that new blood genetic test.
Right.
Because you are high risk. So unfortunately, because of your family history, you are stuck getting colonoscopies, but still for the better, probably in the long run.
And even if you had genetic testing done, it doesn't obviate your family history. Family history sticks there no matter what. Can't get away from our family.
Thank you. Next question. What is your opinion on Cologuard? I'm 75 years old and have had 3 colonoscopies over the years with no polyps found. My last colonoscopy was in 2020. Can I depend on the results of Cologuard instead of my next colonoscopy, which is due in 2027?
So I say that any screening test is better than nothing. If you were my patient, I would still tell you to go ahead and get a colonoscopy. I do think that's the best thing to do. That being said, this will be your last colonoscopy, assuming it's normal. So with a normal colonoscopy, you can go 10 years between. So, and that's kind of the idea of a life cycle of a polyp. As we saw, your increase of colon cancer, just a totally sporadic cancer, does increase with age. So I still do think it's the best option. Again, a Cologuard is better than not doing anything, but I think colonoscopy is still the gold standard, and that's what I recommend for all my patients.
Dr. Gerson, does Cologuard pick up the presence of colon polyps?
Well, that is a great question, Carol. And the other thing I say about Cologuard is, first, if it's positive, you have to get a colonoscopy anyway. And second of all, it's looking for advanced polyps or cancer. you don't want to find those. You want to find them when they're itty bitty teeny and aren't even in the realm of cancer. They're just kind of abnormal cell growth.
Okay, next question. What's one thing you wish more people understood about colorectal surgery?
That's a great question. I think that kind of a double fold. So any colon surgery is absolutely a major abdominal operation. You're kind of resecting a part of your colon and putting it back together. I would say something that wish more people understood, that most of the time people do not end up with ostomies, meaning a colostomy or an ileostomy, if done electively, meaning you don't come in with in an emergency situation. And we nowadays, most people are doing them minimally invasive. So whether that's laparoscopic or robotic. So the surgical technique has come a long way as well. But that I would say probably at least 80 to 90% of patients do not need ostomies.
Thank you. We've had amazing questions from our community. I'm going to close us with our one last question due to time. But I hope everyone continues to reach out to us if you do have further questions and concerns. Our last question is for you, Dr. Gerson. I wanted to know, can hemorrhoids turn cancerous?
That's a great question. I get it all the time. No. Hemorrhoids are a normal part of our anatomy. Everybody has them. It's just kind of when they get inflamed or enlarged or aggravated that they become an issue. Hemorrhoids themselves do not turn into cancer. But important to differentiate as a cause of rectal bleeding from cancer.
Thank you, Dr. Gerson.